stuck, you can always turn to whichever junior doctor's with you and say, help me.
Hello, welcome to the Coffee on Call Medicine podcast, a podcast series to help ease your transition from medical school to foundation. So sit back, put away the textbooks, and grab a coffee. Enjoy. Welcome back to the Coffee on Call Foundation Medicine podcast. I'm here with Kitty.
Morning.
And Imi.
Morning.
And I'm Richard. So today we're talking about communication and particularly what you learn about communication skills at med school. How did you guys find comm skills teaching and stuff at med school?
I felt at uni it was a bit of an ambiguous concept. I felt quite detached. You go to uni thinking that I've done medicine because I can talk to people. Why am I learning communication skills? I remember learning about SBAR, and I remember using SBAR for the first time as a final year medical student and thinking that I nailed it. But I think I was on the phone to an elderly registrar making a referral for about half an hour, which I can now do in 30 seconds. And the elderly registrar, speaking of communication skills, was very patient on the phone and asked all the right questions. And was very kind, and it was certainly a big learning curve for me. But I did not nail that referral.
No.
Sounds like you'd have got their whole life story in there. You'd talk about their childhood.
I didn't even manage their blood pressure.
So did you actually do any kind of referrals and these sort of conversations when you were a student, or did you save that until you started working? Or
I did, but that wasn't really the norm. I think it's quite intimidating as a student. I was certainly quite scared. But it's quite nice to have that practice and that caveat of, I'm just the medical student, but can I try, And normally people are very friendly and they're quite, happy for you to have a go. And if you get stuck, you can always turn to whichever junior doctor's with you and say, help me. And they'll happily take the phone. So
yeah, so you say this kind of went not that well when you tried it, but what do you think you got from that experience? Was it terrifying? How was the experience?
I mean, it's really intimidating when you're a medical student. The thought of calling a registrar, making a referral. I learned perhaps about my own limitations, and actually maybe my communication skills as a medical student weren't as good as I thought they would. And actually, it highlights the usefulness of practice, as in, SBAR is actually a pretty useful tool.
So for anyone listening who doesn't know what that is, I'm sure many people do, but what is SBAR?
Shall I rattle it off?
Go for it, Amy.
Situation, background, assessment, recommendation. So you say, what is the situation? I've got a chap with chest pain, and you give some details. Then you give the background of, they came into hospital with X, Y, and Z. Then you say your assessment. So I've gone to see them and this is what I think it is. And then you sort of make your recommendation or ask your question. So why are you ringing this other specialty? Is it, they've had a heart attack and you think they need PCI, they need stenting, they need something done. And you're sort of asking that other person on the other end of the phone, can you come help me? Is this appropriate? Can I have some advice? And it's just, I think it's quite a succinct, meant to be succinct tool, Kitty.
Unless you're a final year student.
Yeah. But you don't know what's important at that stage, and that's also fine. I think you learn so much from making mistakes. They're not even really mistakes, just less efficient. But you can't start off knowing I'm going to nail X, Y, and Z, especially if you've never done the specialty. Yeah. I have made the cardinal sin of ringing obs and gynae and not having done a pregnancy test on the patient. So don't do that.
So you presumably now take loads of referrals as a oncology reg.
Yeah.
So when you don't get the SBAR handover, do you have any techniques that you use to try and tease out this information? Do you just shout at people? Or,
Do I shout? Depends.
You are quite scary,
what
Kitty.
Day of the week it is. No, and I guess this applies not only to receiving referrals as you get more senior, but as a junior doctor, when a nurse calls you and doesn't use the SBAR handover. And actually, it's much more difficult to receive a referral that isn't via SBAR, because you then have to take a step back from what the person on the other end of the phone is saying and ask those questions directly. So, okay, so what's the background? Okay, so what's your assessment? Okay, so why are you calling? So it's also a tool to use at the other end of the communication spectrum when you're listening to really establish why someone's calling.
Okay, fair enough. So you kind of you walk them through it effectively if it's not been, fine, fair enough. And I don't know about you, if I was going to ring someone, I kind of write this down. I would literally write S bar on a piece of paper and be like, why am I ringing? What's the background? What's all the key information that they're likely to ask? So what's the most recent set of obs like? What are the blood tests showing? That kind of stuff. And think through the conversation before you have it, because then when you are asked, I'm sure nobody goes to work with the intention of being snappy on the phone, but if you phone someone who is not having the best day, then at least you've got all of your ducks in a row, and when they ask these questions, and it feels like an interrogation, and at least you've got the answers. I don't know. Do you guys do that, or is that?
Certainly, when I first started as an F1, I remember being terrified to ring microbiology. And I literally wrote like a script for myself. Clearly had too much time, and tried to go through it. And then obviously that didn't work because they then ask questions that aren't in the script. But then for the next time,
Did you say that back to them? Sorry, this is not in the script.
Sorry. I don't know if you've read your lines, but let me finish. But it's really helpful because then the next time you ring, you go, they're going to want to know what was the penicillin allergy to, you know.
So you kind of learn from it, and now you've got. Well, I guess the script is almost more subconscious now, but you kind of know the vibe. When you phone, they're going to want to know X, Y, and Z, so you have that in your mind before you make the phone call. But that kind of preparing for it and anticipating their needs, I guess. I think that's a form of empathy, really. So you're thinking, what do I want from this other person? But you have to think, what do they need from me in order to help me, if that makes sense? So if I want a senior to come and help, I need to understand why they would come to help, so therefore I need to give them that on a plate. Do you see what I mean?
Yes, and I think clarity in that. You need to be clear that actually I'm asking for your help and I'd like you to come and see this patient, because if you don't say that, then they're not going to know that you want them to come and see the patient. It's
all interpretation then, isn't it?
Yeah.
So I think being quite clear in your needs / in the R bit of S-bar, like being really explicit of, I don't want you to come, but I want your advice, versus I'm asking you to take over the care of the patient, or whatever it is.
Yes.
Yeah, definitely. So we've talked there about verbal communication at work, but I don't know about you guys. I think that written communication is something that is like never really discussed that much at medical school. So, a lot of the exams are now single best answer, MCQ type thing. You don't have to do much written work. And then you start as a doctor, and most of your job, certainly as a junior doctor, is to a degree administrative and involves an awful lot of typing and an awful lot of written prose. And you come to work, and if the notes are not helpful, I think it makes it really difficult. So if you got any tips for communicating well but not verbally?
I think so everyone has their own style when it comes to documenting. For some people, they like to be really, really thorough. For some people, sort of the more A&E type minded people, often like myself, you sort of write out your A to E and that'll do. But I think you've got to imagine if you were the on-call doctor, you've never met the patient and you're going to see them at 2 a.m. So you've got a whole new set of nurses. You've got no one else who's met the patient before to ask. Is that enough information for you to have a reasonable idea of what's been going on so far and what the plan is, and how has that now changed? And remember that obviously it's an old adage, but it's true. If you didn't write it down, it didn't happen. So, there is a medico-legal point in this as well, in that, if you put the NG tube in, I think you should write that down. And what size and some people are more or less comfortable with doing that kind of thing. But remember, it's a record for you and for your colleagues to let them know what happened and when.
It's like a note for yourself in the future. Why did I write this? So I tend to write my actual thought process sometimes. So I will literally write, I am thinking that this is this, and this is why I made these decisions. Do you write like that, or do you just stick to the basic facts?
Yeah, definitely. Before I see a patient for the first time, I think the best thing you can do is just take the time to look through the notes. And as you're looking through the notes, write down either your thought process or actually the salient points that you've noticed whilst you've been going through the notes. Because actually, if you want to know those bits, having been through the notes, the person who sees the patient for the first time after you is also going to want to know those bits. So I think taking the time to write down those important bits before you see a patient is important. And I think you're right, actually, writing down your thought process. Before I go and see a patient, actually, most of the time, I've got the plan written just through knowing the background, which will obviously alter after you've seen it, but just helps formulate your thought processes.
But I guess the patients don't read the textbooks that we read, so what might be a textbook plan might not be what you end up doing, and explaining that in writing is really helpful to people who come up. So in the morning, let's say, the team don't go, oh, why did they not do a chest x-ray? And they look at the notes and it'll say, I didn't do a chest x-ray because they'd had one 3 hours previously, which was, so if you've written it very clearly, then there's much less ambiguity, I guess, around your...
Yeah, and I think certainly when you're junior, I think people are quite hesitant to write a diagnosis, for example, or an impression. But I think that's the most important part of your assessment that you're writing on paper, because it doesn't have to be right, but we need to understand, if I'm now reading your notes, why did you start them on antibiotics? And if you've written, I think this might be an infection, but, query source, I'm going to, do cultures, do my sepsis 6, and I'm going to start them on empirical antibiotics. I now know exactly what you thought. Yeah. Whereas if I just find, they've been on antibiotics for 4 days, why? That's quite hard to unpick.
So all of it, I mean, we're kind of talking in dream scenarios now, where we're thinking well in advance. We've got time to plan. It sounds like a very calm shift where you've got time to be writing a script before we bring micro and stuff.
That was one time, Richard.
But hospitals are a stressful place at times, a very busy, stressful place. So how do you think these translate into those stressful environments? Like, how do you maintain your cool? Let's say, there's a cardiac arrest, or it's a very busy, you're having a dreadful busy med-reg shift and you're in A&E resus. So how do you cope with that?
So there's actually a term called VUCA environment for that sort of environment. VUCA, so it stands for V for volatile, U for uncertain, C for complexity, and A for ambiguity.
Chaos is what it stands for.
I mean, yeah.
It stands
for the NHS.
VUCA equals chaos is what we learned. Okay, cool.
But I think even in a chaotic environment, to actually keep the patient safe, you've still got to be able to just take a step back and take the time that you need to take to plan your conversation, to write the notes.
So I did an ICU job as an F1, which was really, really good. So I kind of had the dream job of being supernumerary and nobody looking to you to make the decisions, because I was essentially like a little barnacle stuck to the ICU reg. You couldn't get rid of me for the day. And I'd kind of just go to all of these quite intense situations, but almost like with a fly on the wall perspective at some points. And the ability of the ICU team to turn up and kind of like take control of the situation, I guess, was really, really interesting to see. And it all comes back to like closed loop communicating, I guess. So do you want to explain to the listeners what a closed loop communication looks like what we mean by that?
Yeah, I'm a big fan of closed loop communication. So certainly we teach it in arrest scenarios, because obviously that's where communication is so vital. But you ask a question and you want that person to sort of repeat it back to you, and the best thing is to name the person if you do. So we might be in a scenario and I might say, Kitty, I want you to go put the crash call out, your 4-2s, and come back to me and tell me when you've done it. And then Kitty might go, yes, Imi, I'm going to go put the crash call out and I'm going to come back. And it sounds a bit silly, but I think this is one of those things that pilots do, that they love to sort of teach us, but it works for a reason, because it doesn't leave any ambiguity of who am I giving the instruction to, what's my expectation, and how will I know it's been done. So it tells, if you're the person receiving the instruction, it tells the other person that you've listened and you're going to do what they've said. And it gives you that opportunity to go, actually, I mean, what did you want me to do? And I can clarify.
Yeah, so it enables you to kind of keep track of the plan. Yeah, that's good. And so as a student, then, you've got to transition, haven't you, from this perspective of a little bit like me as the F1 ICE barnacle, not wanting to be the one asking the difficult questions. You've got to transfer from that state to being the doctor who is having some of these difficult conversations. So what do you think let's say a final year student, what could a final year student be doing to kind of develop these skills whilst they're on placement?
I think practice. I think communication is like learning to drive. And I think the more you do it, the more comfortable you'll feel, the calmer you'll feel having those conversations, and the clearer your communication will be.
Yeah.
And I think as well, like with learning to drive, you know, when you're not very confident and you're at the beginning, in your head, you're going, you know, mirror signal maneuver, or certainly I still am. And then over time, the more you do it, you'll realise, you know, you're doing S-bar, you're doing closed loop, and you're not consciously thinking about doing it. It's sort of woven into your practice.
Yeah.
So yeah, take the opportunities and find someone who's really nice, like me or Kitty or Richard, and practice.
But seriously, though, like if you attend doctor's handover as a student, there's no reason that if you've seen a patient on that shift and you, let's say it's the evening 5 o'clock type board round, if you've just seen one of the patients and they're discussing that case, that's a perfect opportunity for you to practice delivering an S-bar handover to the team, and even maybe a good opportunity to get some feedback on it from the other doctors. And I always thought that one of the ways, or I think that one of the ways students who come to placement could really, like the ones who are excellent, express their expectations from the placement really early on and communicate that really well. So students who come to you as a doctor and say, hey, what I really need to do is I need a case-based discussion. So I'm looking for a case which involves these domains, whatever those are, or I really want to do an ABG, but I've never done it. Can you help? Those who communicate like that and set their expectation, it makes life as a doctor, it makes your life a lot easier to help them. And if you turn up rather as a student who's kind of like, just got to be signed off really, it makes life really hard as the doctor because you don't really know what they need. And so again, comes back to that empathy. So if you want something, what does the person you want it from need from you, if that makes sense? Because it's a two-way street, isn't it? So if you're a student coming to handover and you want to practice handover, be explicit about that. Say to the team, look, guys, I really want to, could I do this? Could I lead the ward round? Could I take that referral? And take a bit of ownership over it, I think would be a good tip.
Yeah, absolutely.
Speaking of tips, if you had one tip about this, so about communication, written or verbal, but just how to communicate as a doctor, and you could put it in a box that we gave as a gift to someone, what would your tip be?
Quite a strange Christmas gift, but you know, not the worst I've had.
Possibly the worst, yeah.
One tip.
Can I give two?
Go, you can give two.
You can give mine if you'd like.
One I've touched upon, practice. It's learning on the job, you will get better and not quite realise how much you're getting better. The other thing that we've not really discussed that I just wanted to touch on is we've talked a little bit about the chaos that is the ward environment, and we've talked a little bit about empathy. And I think there's something about putting yourself in the shoes of the person that you're referring to. And actually, if they're a bit short or they're a bit grumpy, perhaps think about the situation that they're in. Are they covering someone who's off sick? Are they covering the job of two people? Are they, have they just had 16 bleeps in 5 minutes and you're number 17 on their list?
Well, and often you can hear clues on the phone. You know, I'll be ringing orthopedics and I can hear A&E in the background. So sometimes I can preempt that and go, sounds like you're a bit busy. Should I call you back in 10 minutes?
Yes.
And they really appreciate that.
Exactly.
You know?
Empathy again.
Yeah. Or just, this is my number. Do you want to bleep me back when you've got 5 minutes sitting down by a computer? And by the way, make sure someone gets you a cup of tea. You can just, A, de-escalate that grumpiness on the phone, and B, just make someone else's day much better because it shows that you care.
Yeah. I think that's really good. Like, making sure that it's obvious that you care. Yeah, I think that's really, really good. And understanding that they are obviously going to be busy. You are busy, but they are also busy. I think if I had one, I'd probably say, if you have to pick up the phone and the phone's ringing, force yourself to grin or smile before you pick it up, because it's really hard for you to still sound grumpy if you've got a big smile on your face. And answering it, I think the tone of the conversation's set pretty much instantly when you pick up the phone.
Oh yeah.
And if you ring someone and you get, oh hey, it's whatever team, then you feel like you can deliver your handover nicely. If you ring someone and they go, what? Then that's obviously not an open, warm start to that conversation. So be the person who is nice to speak to on the phone, I think is key.
Yes.
I think, mine would probably piggyback off yours, which would be kill them with kindness. In a
figurative sense.
In a figurative sense, we're not endorsing any killing here. But, I'll often pick up the phone and start, morning, I'm Imi, and I'm calling from wherever. Can I run this by you? And, if you're cheerful and approachable, you can sort of set that tone.
Someone asked me how I was when they referred a patient the other day. It was wonderful.
None of your business. But no.
It was wonderful.
That's lovely.
So I think That's probably it for this episode. Should we wrap it up there?
So,
Perfect. Thanks, guys.
thank you very much.
Okay.